Welcome to AETC. Today we will be presenting a patient. Welcome to AETC. Today we will be presenting a case in which a patient has taken a rabies vaccine and post-vaccination he has developed some reactions. Shall we start the class?
Yes.
Sir, an young age patient, he sustained an alleged history of a cat scratch injury on 6th of this month, and following which he has went to a local hospital and taken vaccination, IDRV vaccination. That's the short history, and following which he has developed some rashes along with the fever. That's his short history, sir. I immediately went in my initial 10 seconds assessment. Patient is fully conscious, oriented, and is completely cooperate and comfortable. And I immediately did my primary survey, airways patent, no oral secretion, cervical spine movements, everything within normal limit, no restrictions. Breathing, air entry bilateral equal, saturation maintaining in 99% with a respiratory rate of only 14 breaths per minute. And
after any injection, before all this airway, breathing, circulation, everything is okay. But how do you anticipate a problem in any injection? Anticipate the signs, red flags.
Sir, immediately, first and foremost, there should definitely history that the patient has taken an injection. Okay. If it is an intravenous injection, we expect a rapid reaction. If it is an intramuscular, we expect a delayed reaction. If the patient has taken orally, we should expect a delayed reaction.
Intramuscular injection, we cannot tell it is delayed.
No, delayed, sir.
Injection can produce
compared to
acute
IV,
problem.
Compared to IV,
it
less.
Okay.
And always we have to think of biphasic reaction also. That is, patient can present after 48 to 72 hours. The patient can again develop allergic reaction. So this is the time frame.
What are the airway compromise signs?
Patient suddenly post this any exposure, patient develops sudden respiratory distress. Patient
that all
develops
evident. They see when you are auscultated, you are evident. Lip swelling is most common because many patients initially they will only have lip swelling. The same pathology will be going on in the throat also. So anybody who is you are seeing the lip swelling, that's a warning sign. Okay, like what you are seeing, wheeze is a warning sign, yes, but that occurs after some time. But lip swelling will be the initial phase of the anaphylactic reaction in most of the patients.
Yes, breathing for this patient, breathing, he was maintaining saturation with hardly a respirator of only 12 to 14 breaths per minute, and in circulation, BP he is maintaining around 128/78 millimeters of mercury with a pulse rate of around 68 per minute. All peripheral pulses palpable, peripheries were warm. Disability, GCS was 50.
Want to check a standing BP in this type of patients? Somebody is having an injection reaction.
Sir, actually this injection happened on 6th and he developed everything around the
okay, that's okay. Suppose you are the person who are giving the injection. If the patient tells a complaint like this, do you want to examine the standing BP?
That's basically
one of the earliest sign of hypertension is postural hypertension. Then only you will get the original features of hypertension. So whenever you have time of permitted, the patient can stand. We have to check the postural BP. Okay, that's very important.
Yes. GCS is 15/15, pupils 2.5 bilaterally reactive, GRB is around 121 milligrams per deciliter. Exposure, peripheries were at that time, no external rashes or any edema or urticaria, nothing was present at that time. Since the primary survey is everything appears to be within normal, I didn't ask for any adjuncts at that time. Then I immediately went for my secondary survey. In secondary history, no history of any is only symptoms was that post this vaccination by around 4th or 5th day he started developing fever along with generalized fever, persisting fever, following which he has taken medications and it is not at all subsiding. That is only complaint. History of any allergies. He's on medication, he's already taking antiplatelets and antistatins, and past history is that he is already known case of hypertension and coronary artery disease, double vessel disease diagnosed patient. Even lead to is that patient has an alleged history of a cat scratch. It's from the history it's a category 2 only. There was no bleeding at all.
What are the categories of rabid dog or rabid cat?
Suspected rabies injuries we categorize into 3. So category 1 means that the patient is just licking of the skin is completely intact. So in such scenario we don't have to do any vaccination. Correct. Category 2 means that conditions like scratches or any injuries, but there is no active bleeding. The blood has never come out, means it categorized into category 2. In category 2, we usually go ahead for a vaccination alone, but in patients with a high risk individuals like immunocompromised or patient having HIV or something or on chemo drugs, such patients we will have to give immunoglobulins also in category 2. In category 3 means that definitely it's a deep wounds or with significant bleeding, then we have to take it into category 3. Category 3 treatment always you have to give vaccination along with immunoglobulins.
Which all the area bites of rabbit, dog or cat? Which all the area bites are more dangerous?
More proximal to the head, it is more dangerous because
So
it's a retrograde transmission. So more chance of reaching the brain is more. As the wound is more closer to brain, chance time to travel is less. So it's a category 2 wound, following which he has went to local hospital. There he has taken IDRB on the 0th day and on the 3rd day.
So 0 day means on the day of admission,
day of the injury, and on the 3rd day. By around 5th day, he has slightly developed to have fever. And
5th day from the second dose or
from the first dose. So he started having fever along with the headache. So he took some oral antipyretics, but its fever was not subsiding. It was multiple times recorded around 99 degree Fahrenheit, for which he has went to local hospital, and there they have found to have mild OTPT elevation to less than 100 but around 67 and 70s range, along with the thrombocytopenia to less than 1 lakh. Exactly around 50 and 70,000 platelet count was found. Following which, in view of persistent fever and thrombosis.
Somebody come with come like this. What are the differential diagnoses you think?
Now we have to think in two possible ways. One is it is an isolated case of fever with the thrombocytopenia.
Any fever,
viral fever
doesn't related to the current problem.
Then next thing is that it may be a reaction to the vaccination that he has taken, or it may be because of since it's an injury from this cat, it may be due to any secondary zoonotic infections. For example, in case of cat scratch disease or something.
Last one will be rabies itself.
Rabies itself. Since he is vaccinated, chance of getting into a rabies vaccination will be less.
Very less.
So that will be our gross DD. So
can the vaccine become ineffective in any case if you don't maintain the cold chain properly?
Yes, sir.
And it is an ineffective vaccine.
Yes, sir.
Okay, but here he has taken from a good center and government center, and he has got two vaccines. Important 2 days of vaccination, and we have to see what happened to the cat. That is also important.
So that was his event why that led to arrival to our hospital. Then we did our quick head to foot examination. In head to foot examination, head is appearing normal, no cervical lymphadenopathy, no oral swelling, no urticaria, no signs of any edema, no laryngeal edema, no
cat scratch fever is what?
Sir, it is actually a infection that is secondary to whenever we have any injury from the cat, sir. Patient will develop the bullae-like lesions along with cervical lymphadenopathy nearest to the injury. It is usually caused by Bordetella hensel bacteria, and usually we can treat this patient with drugs like doxycycline or azithromycin is more than enough. Many patients it will resolve spontaneously also. So this patient, then in our head to foot examination, no features of airway obstruction or no features of any allergic reactions were present at that time. Then I went to the breathing. Air entry is maintaining bilaterally equal, no added sounds, no tachypnea, saturation is maintaining in room air, and no tachycardia, cardiovascular resonance was audible, no other murmurs were audible, and abdomen also soft and non-tender, no episodes of vomiting or diarrhea or abdominal pain was there, and in musculoskeletal examination also no visible rashes or no other palpable lymph nodes, nothing were detected at that time, sir. So as a provisional diagnosis, the possibility of fever with thrombocytopenia along with the possibility of a drug reaction we suspected, and we started investigating the patient. So we sent for the routine investigation. Our routine investigations came with a normal hemoglobin of around 12, and a platelet was at the time of our admission more than 1 lakh. It is around 1,25,000 platelet was there in our inside hospital, and otherwise his OTPT compared to the outside hospital has come down, and but his CRP compared to the outside hospital labs, it has elevated to around 73, sir, and otherwise in initial day of admission, other RF, LFTs and other coagulation parameters and electrolyte parameters were within normal limit. And but on the subsequent day, we found to have again he started to have a rise in total count. Total count he started climbing to around 24,000. His CRP started increasing, but LFT parameters everything started coming down. So we have sent for an peripheral smear. Along with that, in the episodes of fever spikes were there. So we sent for a peripheral smear. Along with we sent for a procalcitonin also. Procalcitonin came to be 2. So as possibility of a sepsis we thought of.
Sepsis means it has to be very high.
High.
2 means a local infection.
Possibly
That's
because
all.
already he was receiving an high spectrum antibiotic of piperacillin from outside hospital.
So procalcitonin will not come down in 1 or 2 days. It will take some time. So 2 means there is a local infection that may be producing systemic inflammation. But once there is a systemic infection, procalcitonin has to be slightly higher.
Then we did the peripheral smear also. Peripheral smear was also suggestive of only some kind of inflammatory changes only, sir, and thrombocytopenia. But manual count also it is more than 1 lakh is present. No other atypical cells or nothing were present at that time. Since in view of persistent fever, we did an ultrasound abdomen also. It was showing only mild fatty liver, and we for the next day we sent for urine routine examinations also. In view of initial day thrombocytopenia is present, in view of percentage fever spike, then we found screening test for dengue, lepto, and malaria was also done, but everything came to be negative, sir. And and on the second day of our admission, we started noticing him that he is having petechial rashes all over his lower limbs and he is in upper limbs and a decreased amount in his chest, but not in the face. All other peripheral areas we started to knowing petechial rashes. It is not palpable and it is not blanching, sir. This was his finding. So
If you have rashes, any other thing also you need to add? Location is? Any mucosal?
Mucosal involvement also has to be there, but there was no oral ulcers present, sir.
Oral petechial rashes are very important.
Oral
like SLE and all, you get oral petechial rashes.
So it was not there, sir. So we sent for the ESR was sent. ESR was also found to be elevated around 49 was present, sir. So anyway, in view of rising CRP and parameters, we started him on antibiotics was started.
Broadly, how do you classify the purpuric rashes?
Sir,
this patient is having purpuric rashes. It can be due to a fever, it can be due to the vaccine itself, or something else, immune mediated disease. But how do you clinically classify?
Sir, the small lesions we again broadly classified into petechiae and purpura. Petechiae when it is more than 3 millimeter. If it is more than purpura, 3 millimeter, we can call it as purpura. And if it is more than 5 millimeter, we can say that ecchymosis. In petechiae or purpura, broadly we have to see whether the patient is febrile or afebrile. If it is both in febrile or afebrile, again we have to see whether it is a palpable or non-palpable purpura.
Febrile purpura, where all is it?
Afebrile purpura, patients with ITP, sir. ITP, the patients will be usually febrile and non-toxic.
Physiologically, can you get purpura?
Vasculitis and
physiologically. Physiologically, elderly individual with senile purpura. Sunlight can produce purpura. These are the physiological conditions where you get purpuras.
So, if this patient is febrile, again, if it was a palpable, then we have to think of a possibility of Hinone-Schonli purpura.
So, palpable is vasculitis. In that, one of the vasculitis is HSP, small vessel vasculitis. What is the typical feature of HSP?
Sir, Hinone-Schonli purpura, usually 4 things has to be considered. There should be a palpable purpura should be there, renal involvement should be there, sir.
It's not a must. Can be there.
4 features are there. Then along with that, abdominal pain and arthritis.
The most common clinical finding is upper limb and lower limb palpable purpura, especially in the lower limbs. Most of the time, it does not create any clinical problem. All these things what you told, this second, third, fourth is a complication of HSP. Okay.
One other differential which we had seen was that neglected patients usually come with this, any insect bites or ant bites and all. So
multiple ant
usually we will go in completely other directions.
Yes, sir.
So keep that also in mind.
So, and otherwise if it is non-palpable, then we have to think of a DIC or TTP has to be also considered. And if it is patient is afebrile and still having a palpable purpura, the possibility of having autoimmune or vasculitis, everything has to be thinking.
If the hands are involved, legs are involved, What are the differential diagnoses?
Again, two things. Hand, foot, mouth disease should be
It's
think
a
also.
viral disease.
Viral disease.
Age group?
Usually it is common pediatric age group, but adults can also develop. Usually it's a viral infection, and patient will have lesions all over his hands, including oral cavity will also be get
Correct.
involved. But
They are
it is a-
slightly bullous lesions,
on bullous lesion.
completely purpuric lesions.
Painful but highly contagious,
Contagious.
and thing is, but it's self-resolving.
Okay.
But the patient, if it is in adults, the possibility of getting into CNS and cardiovascular respiratory involvement can be there.
Palm purpuras are seen in which condition? Palm.
Drug reactions.
Drug reaction is the most important condition where you get purpuras in the palm.
Palms reaction. So, since in view of the presence of non-palpable lesions, we have taken for a dermatology consultant for a biopsy, and we have sent the sample for biopsy, sir. Now we are awaiting for the biopsy report. Currently, after we starting the antibiotics, we have started him on antibiotics, and after that, his actually fever spikes has come down.
Most of the time that will come as leukocytoclastic purpuras. There is small vessel vasculitis which does not have any major clinical implication. Okay, that may be part of some other disease.
Currently his actually CRP started coming down today, and his total count also started coming down today, sir, and he is symptomatically febrile for past 12 hours, sir. And we are awaiting the biopsy report. Status of the patient.
Okay.
Can you elaborate something more on serum sickness?
Sir, serum sickness, actually we have 4 type of hypersensitivity reaction. Serum sickness comes under the type 3 hypersensitivity reaction.
You tell first type 1, type 2, type 3, type 4.
Sir. Type 1 hypersensitivity reaction, it is an IgE mediated reaction. IgE, that is bound to the mast cells. When it is come in contact with an antigen, sudden degranulation and release of histamine and leukotrienes, everything happens. Usually it is seen in conditions like anaphylaxis reaction, urticaria, all allergic symptoms. It all comes under type 1 hypersensitivity reaction. Type 2 hypersensitivity reaction, whenever there is an antigen and antibody mediated reactions, like reactions that are involved in blood transfusion, autoimmune hemolytic anemia, this all come under type 2 hypersensitivity reaction. Type 3 means antigen antibody complex mediated reactions. It is seen in conditions like SLE and this serum sickness, all these conditions, and PST and post-streptal glomerulonephritis, all these are immune complex mediated. This serum sickness comes under type 3. Type 4 is delayed hypersensitivity reaction due to T cells, usually seen in post-transplant rejections, everything. These are all delayed hypersensitivity reaction. So our serum sickness, it is usually seen in whenever the patient is receiving an outside serum, outside proteins, especially proteins from an host derived proteins or something. These patients usually develop symptoms around 7 to 14th day. It is usually because of antigen antibody complexes has formed against that, and these eruptions or lesions usually appear first in the nearby site of injection itself. But gradually patient can develop a severe arthritis with effusion, and gradually these rashes can spread to other area also, and this erythematous rashes initially will get converted into palpable purpuric rashes, but usually it is self-resolving, and by around 14th day patients will start, the pigments will start disappearing, and the symptoms usually subsides. This is a serum sickness.
Have you done ferritin levels in
Yes, this patient ferritin has been done. It is elevated to around 1000, sir, but possibility of HLH was thought. But
HLH is when the patient is unstable only we are thinking about HLH. This patient, what else you can think when we are asking for a ferritin? What else?
It is an acute phase reactance.
That's okay. But if it is very high, 10,000, 20,000,
hemochromatosis.
what autoimmune disease? Somebody is saying fever, rash disappear after fever. Still's adult onset Still's disease. There you get typical feature like high degree fever. During fever you get this type of rashes throughout the skin, and once the fever subsides, the rashes subsides. Patient can have joint pain also. Here also this patient is having joint pains. But ferritin is not very high, so we will not be thinking about that. I just told how is the patient. Now the problem is whether we can advise this patient for the third dose of the vaccination or not.
Not, yes, sir.
What is your advice?
Currently, for as if now, we don't know, because sometimes if this reaction is secondary to a vaccine exposure, possibility of developing an anaphylaxis next episode is very high, sir. One thing we can do is that we can hyperdilute and see for any skin test and see whether a patient is developing
skin test will not work because already is exposed. Even skin test also will produce anaphylaxis.
So
whether to give vaccination or not in this patient is a question, because if suppose this cat is missing, you are not seeing this cat and we don't know what happened to them, definitely we have to give the vaccination because his life is more important than reaction.
Yes, sir.
Then you take all precautions, like you keep the adrenaline ready, intubation set ready, everything should be ready, and you give the vaccination because that will save his life.
Yes, sir.
Okay, that has to be done.
Yeah.
Here the cat is surviving even after 10 days. There you can take a decision. We can tell the patient there is a problem. If the patient is giving consent for a third vaccination, we have to give the vaccination. Otherwise, we have to wait and observe the cat.
Yes, sir.
Suppose the cat dies, what do you do?
Actually, if the cat dies, then we have to give the immunoglobulins.
No, cat dies. How do you diagnose?
From the cat.
From the
We
cat.
can send the biopsies.
You have to send the patient, the cat for postmortem and take the brain biopsy and see. That normally they will do it. Veterinary doctors will do it. So we have to ask for that. Suppose the cat dies.
Yes,
Otherwise, it's okay. You safely monitor the patient and ask the consent of the patient. If the patient gives consent with all precautions, you have to give the third vaccination. Third, fourth, and fifth should be given, because we don't know whether the cat will develop or not.
Okay, sir.
That has to be given. Anything else?
And regarding the regimens,
So whether we have to give any antibiotic for this patient? So is it a vaccine related illness or something else?
That's a question, sir. We are waiting for the biopsy. It is unlikely to be.
Biopsy will ultimately it will give a diagnosis of a small vessel vasculitis. That's all. Because we don't get anything from this one.
It's not so sure, sir.
Looks
It's
like a
unlikely
viral illness.
Looks
like a
unlikely to be. It's due to vaccine.
vaccination mostly.
Dengue, negative, everything negative.
Okay.
Dengue, lepto, everything we have sense.
Since patient has improved, we will not be doing further investigations.
And then regarding rabies vaccination regimen also, I will
Okay.
also. Sir, ideally, post-exposure prophylaxis, two options we have. We can either give intradermal or an intramuscular. Both are same vaccine, chick cell embryo derived vaccines. If you are giving intradermal, advantage is that we have to take only 4 shots.
Okay.
0th day, 3rd day, 7th and 28th day.
Okay.
But we have to take on both the deltoid areas, but only hardly 0.1 ml is enough. But we have to take only 4 doses. If you are giving intramuscular, we have to take 0.5 ml, but only on 1 deltoid or 1 in the buttocks area. Only 1 shot is enough, but you have to take 0, 3, 7, 14 and 28th day.
Okay.
So, but the major question arises whether to give immunoglobulin or not. So, whenever there is a category 3 wound, or when the patient is having a high risk categories, like the patient is immunocompromised, or if the patient is category 2 with the immunocompromised. In category 3 itself, if the dog is having any ill-looking features, or if the dog is highly suspected of rabies vaccination, we have to give in all categories, irrespective of what, we have to give ARIG or IG immunoglobulin also. In immunoglobulin itself, commercially 2 types available: equine derived rabies immunoglobulin and human derived. But HRIG is very costly, but the dose is only 2 international units per kg is enough. But ERIG, if you are using 40 international units per kg, will have to be used, and maximum possible dose should be given at the site of bite. Remaining can be given to by about opposite shoulder or the buttocks. And regarding the post-exposure prophylaxis for a patient who has already taken a pre-exposure prophylaxis, or already he has received a full course of vaccination, if he again gets a cat scratch within 1 year, only 0th dose and 3rd dose is enough. Only 2 doses is enough. And how to get a for example, if the patient bystander who is dealing with a rabid patient, or a patient or a veterinary doctor, to take a pre-exposure prophylaxis, only 0th and 7th dose of intradermal or intramuscular vaccination is enough. It will give around 1 year of
newer protection. Anything is available, newer treatment for prevention? Monoclonal antibody it's like something like injection. It's not monoclonal antibody, monoclonal immunoglobulin, that is also available at present. Okay.
Yes, sir.
WHO has given agreement for this
use of marijuana.
use of this one, but it has not come to Indian guidelines.
Okay.
Okay.
Yes.
And if somebody gets rabies,
How do you manage?
I mean, if he gets infected with rabbit, and sir, the prognosis is very bad. Major issues that it's a very painful death. Usually, such a patient should be kept in a silent room because all the stimulus will be painful. If possible, early analgesia and sedation and paralysis of that patient would be ideal. Prognosis around 99% mortality for rabies, but it is 100% preventable. But once it's getting infecting the brain, means mortality is very
just only palliative.
palliative treatment only.
And this human to human transmission is very less likely.
Less likely. Usually in India we have mainly rabies seen in the cat and dog bites. In Western countries in wolf and in vampire bats. In Indian bats it's fine. Vampire bats in Western countries are all found to be rabbit prone.
Okay.
Okay.
Thank you.